Good afternoon, everyone, and welcome. I'd like to welcome you all to today's Public Health Practice Grand Rounds for March 2012 on behalf of the Mid-Atlantic Public Health Training Center here at the Johns Hopkins Bloomberg School of Public Health, as well as on behalf of the Maryland Department of Health and Mental Hygiene. I'd like to welcome you to the presentation on the state health improvement process, how local coalitions are achieving health care reform's triple aim. And just briefly, before we begin today's presentation, I'd like to invite all of you watching online to look at some of our trainings that are coming up, both face-to-face and online. We do have a number of archived webcasts, so for those of you who missed some of our other webcasts, they are archived on our website, and just let others know that we're not able to view this presentation today, that this will also be archived on our website as well. And some of our face-to-face trainings coming up include practical grant writing, community assessment, and the ethics of public health. And we also have next month's Public Health Practice Grand Rounds on reducing asthma disparities in children. And again, for those of you who are watching online, we invite you to both email questions for either of our presenters at any time during today's webcast. And we also encourage you to sign in so that we can let our federal funders know how many people were watching. And with that, I'm going to go ahead and introduce today's speakers. We have with us Dr. Madeleine Shea. Dr. Madeleine Shea is providing leadership and direction for the Maryland Department of Health and Mental Hygiene as it seeks to improve public health infrastructure, population health, and public-private partnerships and systems alignment in light of healthcare reform. She has spearheaded the 2011 to 2014 state health improvement process that aims to improve population health and health equity statewide by providing baselines and targets for critical population health determinants and outcomes, as well as support for local health planning and action. Dr. Shea holds a bachelor's in economics from Trinity College, Washington, D.C., a master's in management from Johns Hopkins University, and a doctorate in public policy from the University of Maryland, Baltimore County. She began her health and human service career in 1983 and in the U.S. Peace Corps in Liberia, and has worked in the fields of community economic development, health promotion and prevention, program evaluation, home environmental health, community health, and health policy. Dr. Barbara Brookmyer is also joining us today. Dr. Brookmyer serves as the lead health official for Frederick County, Maryland. In the role of health officer, she directs the Frederick County Health Department's 7 divisions and their numerous programs, including immunizations, WIC, cancer prevention, emergency preparedness planning, dental services, well and septic inspections, substance abuse and mental health counseling, school health services, and programs for developmentally disabled children and adults. Dr. Brookmyer previously served as Deputy Health Officer on the Eastern Shore of Maryland in Somerset County and Dorchester County. Additionally, she worked as a family physician in the migrant and community health centers in both of those counties. Dr. Brookmyer earned a Bachelor of Science degree in toxicology from Philadelphia College of Pharmacy and Science, her medical degree from Hahnemann University, and a Master of Public Health degree from Johns Hopkins University. And both of our presenters today are also participating in the Frederick County Local Health Improvements Plan's Dental Access Action Plan, which will participate as one of 20 teams nationally funded by the National Leadership Academy for the Public's Health. Dr. Shea and Dr. Brookmyer will be part of a local state leadership team working to improve specific, measurable public health problems while developing team leadership skills. The leadership program is designed to support a multi-sector collaborative leadership to make a meaningful difference in the community. With that, I'm going to hand things over to Dr. Shea.
Thanks, Molly. So I'm going to be setting up a discussion about local health, state health, and federal health policy. As you all know, there's been lots of talk about healthcare reform and what that means for us in public health. It was a great win. It meant a lot of things we've worked hard for as public health practice people. But it's also brought in a lot of change. And so a theme for our talk is the triple aim. The triple aim means that when we reform health to help the nation be healthier, that we would be looking not just at costs and not just at access, having insurance, but the experience of care, health equity, and quality. So that's what we're doing here in Maryland. Okay. So, no news. In fact, it seems to be daily news that healthcare in the United States is expensive and way more expensive than other countries, and the costs have kept rising. So despite the fact that we spend 2 times as much as other wealthy nations on health, we only rank 42nd in terms of health outcomes. And that's from the Organization for Economic and Cooperation and Development. Okay, quality can be great. It's great probably within a few feet of where we stand right now. But the quality of healthcare in the United States is really inconsistent. What you see here is a map. It's the Dartmouth Atlas of Healthcare. This is just one of many if you Google Dartmouth Atlas, that shows you the percent of diabetic Medicare enrollees receiving appropriate management, and in this case, it would be hemoglobin A1C3 screening. And the dark areas denote a higher percentage that get this screening, the light areas that don't. So you can see there's wide variation within states and across the country. And just this is one picture of, we could have had a whole presentation on this. So another thing coming into reform, and this is one where I think public health has been working so hard, is the context of health in the United States is very unfair. There's huge disparities in access. So according to the Agency for Healthcare Research and Quality, 30% of Hispanics have no access, regular source of health care. That's true for 20% of blacks and 16% of whites. It's a lot of our population. An example of this, to make this come more alive, is the time between an abnormal screening mammogram and follow-up diagnostic test is twice as long for Asian Americans, blacks, and Hispanic women as for white women. And it's not real fast for anyone. Again, there could be many, many examples. This is just one picture. Another area where we see that things aren't fair is the disparities in outcomes. So nationally, black babies are more than twice as likely to die as white babies. African Americans and Hispanics are more than twice as likely to have diabetes than whites. And about 78% of, and this has been in the press a lot in Maryland, 78% of HIV-infected women are minorities. So this is where we were when this momentum for reform was charging. So in the Affordable Care Act, there was an aim not just to increase insurance, not just to reduce the costs, because you saw that first slide, our costs are unsustainable and affect a lot of things, including even our economic competitiveness, but also to improve the health of populations, a focus on population health, which is our focus in public health. And this is about access, it's about quality, and it's about equity. Another part of the triple aim was the experience of care, which can get at health literacy and just that whole interface between the provider and the patient. So, goal number 1, increase access and equity. We see huge increases in insurance. You see that with the expansion of Medicaid. young people being able to be covered by their parents longer, no pre-exclusions. I'm not an expert in this, incidentally. I have the focus on the population health from the public health perspective, and there's experts in all of these areas of these goals. But basically, we all know that there's huge expansion in insurance and access. And also targeting those who haven't had it, have low incomes. There's a big emphasis on increasing quality. So looking more at health systems, environments, and policies that are the context for how we live, learn, earn, play, and why we get sick or why we don't live to our full life expectancy. There's also, particularly on the public health side, a goal around decreased cost, and this is through increased investment in prevention. And prevention at these systems, policy, environment levels. Some of my colleagues, when I was preparing for this, said, don't forget, the reform really doesn't get at the price of health care. So that might be something that is missing. It's not really our focus, but ultimately the resources that we have for health does affect us in public health. So this is all a pretty big jolt for us in public health, because with this expanded insurance for people who've been part of the safety net served by local health departments and state health departments, some of those needs are going to be met now in new ways, in ways that that are great. We're very happy about this. But it's not a growing pie of money. So this is going to translate, and already has been translating, into reduced categorical funds in public health and block grant funds. So the things that we've been doing for decades and doing very well, those resources are going down. So that raises a question of, new ways of meeting safety net needs, new partnerships, new strategies. Another jolt is, in this new environment, the role of public health in assessing the health of people in the community, this population health, but wherever you are, so for Barbara in Frederick, is very important, because if we're focusing on systems, someone has to be looking at how those systems are working. We can't just be looking at our own, did I do this grant correctly, which many of us here are very, very good at. But that isn't necessarily, we could have some major gaps and things that fall through the cracks if that's our focus. We also are going to need to assure. So when we see that things aren't working well with these population health goals, we're going to need to be able to get in there and help resolve the issues and do the realignment, do the readjustments that would be necessary. There's also a really different focus for quality. I definitely, and I see a colleague from years ago when I worked in HIV and AIDS, became expert in how you do group-level interventions and individual-level interventions with great outcomes. We became very, very good at that. That's where things were. But I don't know how many of you, hopefully this is kind of old, but the Frieden pyramid? It's the health impact pyramid. I don't know who's seen that, but the whole approach to public health has been turned on its point, or on its head. Used to be that a lot of our funding and our programs and where we put our attention was on the individual level, the group level work. And with reform, now the bottom of the pyramid is all about socioeconomic factors, changes to the environments that make it easy or not easy to be healthy. And this is not where the focus has been in my lifetime, and I've been around pretty long. And now at the very top, the tiny little piece at the top looks at education and counseling, those kinds of public health interventions. And with this changing pyramid comes changing funding, at least from the national level. So out with that, and in with the prevention fund, which is giving us new resources to assess and build public health infrastructure, policy, environment, and systems. I'm funded through an infrastructure grant, and there's 50 people like me in the country who have this funding, and it is to look at public health systems, to prepare us for accreditation, public health accreditation, which will assure the public that we as health departments, be it at the local level or state level, can measure up to what some basic expectations would be about public health, much like you'd have in policing, hospitals, really in any other field. There tend to be these standards and accrediting processes. Now that's come to public health. So the infrastructure grants focus on that. Brand new. Community transformation grants look at the more integrative approaches to chronic disease and looking at the policies, environments, and contexts for chronic disease. At the same time, old chronic disease grants went away. So this is not like additions to all that people had been doing. There's been a taking away from those old kinds of programs and then putting money towards these more infrastructure type things. Million Hearts campaign is out of HHS and looking at tobacco, the individual factors that affect cardiovascular disease, as well as clinical interventions. Winnable battles, another thing, looking really at policy. A lot of those are policy areas to affect public health. So it's a sea change, in my perspective. So this is putting a big squeeze on because we've got the things that have funded us for years all decreasing pretty dramatically, huge new demands around infrastructure, policies, environment, systems. At the same time, we've had decreases in funding overall, and you can see on this next slide that at the state level, we're heavily dependent on federal funds. We also have state funds. Now I'm speaking nationally here. And at the local level, that's true too. Well, we have federal deficits, state deficits, local deficits. There's places where departments are closing down. You've heard about fire departments closing their doors. So it's pretty tough to retool sometimes when you're already doing certain things, you have a certain capacity, and you're called to do a lot more. So I'm just going to really gloss over. Maryland has a really vigorous response to this whole new environment, much of which I am not the expert in. So, for example, we've got great minds working on building a health benefit exchange to increase options for insurance for small businesses and individuals. We have a bill that is right now in the legislature to create health enterprise zones and decrease disparities. We have a lot of work being done on a health information exchange so that to reduce the costs and increase quality of care by more sharing of information using technology. It's a difficult thing, and public health will be at the table here and hopefully a beneficiary of that. There's healthcare innovations, and I'll show you a place I want you to check out, and also patient-centered medical homes, a way to improve the experience of people in clinical care, reduce costs, and dramatically increase quality, although they haven't been evaluated yet. So if you go to the DHMH website, or for people out of state Maryland, DHMH, you'll see along the banner, you can look at our innovations in healthcare. And so here, one thing that the state is doing is trying to get out best practices that we have here in Maryland around clinical innovation, financial mechanisms of care, and then integrated financial and clinical. But now we're to the area I know more about. So one of the areas where the state responded was in creating this state health improvement process. It's a process, it's not a plan, because our philosophy was that health happens locally. Any plan that we would have put together, even if we talked to everyone in the state, would be outdated the minute it was printed, so that we were going to set up a framework for population health improvement with all the tools that we could to drive and support local health action. Part of this, so the goals, population health improvement, which is a big goal in the with healthcare reform, and our process aimed to support aligned action between public health, hospitals, FQH, federally qualified health centers, community health centers, behavioral health, schools, aging services, veteran services, whoever really were stakeholders in population health at the local level. Our real goal was to support or to increase the life expectancy in Maryland, and not just overall, let's say, for white women, but also for black men who have a 10-year less of a expected life than a white woman. You see that all over the state, at the local level as well as at the state. And how we're going to do that was to launch and support this aligned local action partnerships. Partnerships are huge here. And then to have a framework for health improvement with we chose 39 health measures. These are health determinants, social determinants, they're health outcomes. They come from highways, they come from schools, they come from hospitals, they come from public health registries. So a whole array of indicators that represent what it means to be healthy, and for each of these, or things that affect whether we're healthy. And then for each of these, we have state baselines, we have county level baselines, we have 2014 targets that are framed by Healthy People 2020. Healthy People 2020 gave us a great context for this, and benchmarks that then benchmark nationally. And we have racial and ethnic disparity information, baseline information, for 28 of the 39 measures. Let's see if I hit all the points. So an example of a social determinant, just because this could seem like gloss right over, is high school graduation is one of our indicators, and the Institutes of Medicine did say that that's a leading indicator. It's the leading social determinant, and we got it first. So, so an illustration here would be that at the state level, you can see through our SHIP web-based profile around hypertension emergency department visits that the experience of care might not be very good for African Americans. You see the big disparity here. You can also get a sense of the cost of the problem. These are emergency department visits. That's an expensive place to get care, as well as possibly the quality of primary care for hypertension. So this just gives you a flavor. For 39 of our measures, we have pictures of the baseline, the targets, and disparities where we have that information. We also provide county profiles to support local action. So, for example, here in this county, you can see that they're doing better than the state for asthma emergency department visits or diabetes, hypertension. It's in green. The people in their coalition can see where they fall compared to the state average, and then also compared to the 2014 target. So they might be a little bit better, but they might have work to do to reach a 2014 goal and help us all reach that. But you can see they're definitely having issues here with heart disease deaths and cancer deaths, so their mortality statistics are falling below the state baseline. And it's just easy to see with color and these profiles to see for local coalitions to see where they fall. You can also see that we've got some issues around adults at healthy weights, and smoking. So that coalition might begin to get a sense of where they might want to be acting. Our data, we also wanted to give the coalition members a new lens on racial and ethnic disparities. So, for example, here you can see that for adults who currently smoke, the smoking rates are twice as high for whites as they are for blacks in this county, and the data source is the behavioral risk factor surveillance system. They don't do as well as our state. They're not doing as well as the state overall, the state average, but also there's disparities here. And it's one of the ones that's more unusual. I know this is a rural one, where you would see greater disparities with the white population in that jurisdiction. But if you look at heart disease death rate, blacks would be more adversely impacted than whites for this county. So this just gives you a sense of how the state health improvement process is supporting local health action and their understanding of the health of people in their communities. We launched in September. We started about a year ago with this whole process to develop our measures, and we launched in September by presenting county profiles in the counties with new coalitions and some coalitions that had existed before. And these are the kinds of people that were involved, just as we had hoped or wanted to support. We really do have very broad, really exciting participation in these coalitions. It just makes me so excited. And if you go to our website and you want to get involved, I've got to put a plug in. If you go under local action, you can click on any jurisdiction and see where that, go right to the website of the coalition there, and see who to contact, what their action priorities are, what their health profile is, when their meetings are, and get involved. We'd love for you to do that. So hospitals not only came to the table as leaders and partners, but they supported with over $450,000 the startup costs for coalitions that were new and needed to help for planning support or pulling local data together. There's a range of things that this money was used for. So they're not only helping to lead, but they're helping to fund this. And the action priorities just came out from the coalitions, and several of them are working together on the community health needs assessments. So the IRS required health needs assessment that a hospital does now won't be done, not that they always were, but just by itself, a hospital hiring a consultant, but rather will be done in partnership with all of those community partners in public health. This is really wonderful news for all of us. In case you're curious, all of the 17 coalitions have set priorities. 16 of 17 are prioritizing obesity reductions, specific obesity reductions in specific populations. You can see healthcare access was also a huge issue. That could represent primary care, specialty care, behavioral, but in a lot of areas, people couldn't see a doctor if they desperately needed to in a setting other than a hospital. Tobacco cessation, smoking cessation, behavioral health, you can kind of see where these population health focuses ended up. So, in terms of the triple aim, I would say that the coalitions have proven that they really are having a population health focus on specific goals. They're also prioritizing racial and ethnic disparities, either as a group, like we're going to look at racial and ethnic disparities in toto, or within their priorities. So, for example, in the Mid-Shore, they're interested in reducing the racial disparities in high school girls' obesity rates. So that's a specific focus within obesity. It can go, different coalitions they all have their own flavor and style and that they bring to their work. They are definitely focusing on costs. Many of them are looking at reducing emergency department visits by partnerships with public health, hospitals, and community members to assess and address the reasons why people are ending up in the emergency department for conditions that should be better managed through primary care. And also this big emphasis on healthcare access. An example of this, here's one in Prince George's County. They have specific goals for, let's say, their children who receive dental care. That's the fourth row. They would like to see a 5% increase from their specific baseline in the percentage of, this is Medicaid children, who are accessing dental care or did in the prior year. We know that's very, very important to many other health issues just beyond dental care. And actually, you'll hear more about this, I know, from Dr. Brookmyer. There's more support coming for the coalitions. I think this has been a great setup for population health for this state. So $600,000 will be awarded in April to the 17 health improvement coalitions around their top priorities for population health action. Dr. Brookmyer and I and a team from Frederick County received an award to as you heard from Molly Mitchell, to the National Leadership Academy for the Public's Health to develop better leadership approaches to solving problems where we don't have ready financial resources. Hospital community benefits programs are, based on discussions that have already happened in the coalitions, are likely to support action also. There was a recent award that we received in partnership with the Maryland Women's Coalition on Healthcare Reform to increase participation of women of color in coalitions. So having this infrastructure, this framework, I think really sets us up to do a lot more good work in times that are admittedly very, very hard for all of us in public health. The community transformation grants, that was $1.9 million a year for 5 years that came in around comprehensive chronic disease goals. This is also building on the work of coalitions. You could see they prioritize tobacco and obesity, access, chronic disease-related goals. And there's a new Institute for a Healthiest Maryland that is being launched that will build local capacity in these types of interventions and also local funding to support these actions. So, Don Berwick, the guy that coined the triple aim concept, and if you Google it, you'll see lots of articles, said that it was very, very important for us in reform, if we're going to improve population health, to have integrators. And that is, again, coming back to hospitals don't just look at their bottom line. Public health looks at whether they managed a grant well. But we all come together to see who's integrating what's happening for people in communities and how health conditions and outcomes are improving. And it might be gutsy, but I would like to propose that these coalitions have a unique promise for their ability to focus on population health goals. We'll be updating their dashboards every year for how they're doing. And to provide this structure to develop, implement, and continuously improve a common agenda for medicine, public health, and communities. So I would invite you all to follow our progress, to get involved in the action wherever you live. And you can do that by going to our website, by signing on to our listserv. You can do that easily from our website, following us on Twitter, friending us on Facebook. These were new actions for me, but we offer whatever works well for you and invite your participation. And I'm really excited then to turn it over to my colleague, Dr. Brookmyer, who's really making it happen.
Thank you, Dr. Shea. Okay. All right. Well, as Dr. Shea had mentioned, that it's really the state health improvement process is really setting, here I've got the wrong slide up here, is really setting us up in Maryland to be able to achieve that triple aim. And so I won't ask for a show of hands in the room here, but when the triple aim was first introduced as, I guess, a concept or a vision, I didn't really pay much attention to it. And even when it last year was brought out in the context of the Patient Protection and Affordable Care Act, I didn't pay much attention either, and I won't ask how many of you there in the audience read this and said, oh, you know what, we need to get a planning team together, we need to strategize to figure out what we can do to meet this challenge, meet this charge. So again, you don't have to show your hands, but looking at that triple aim of improving the health of populations, reducing the cost and the experience of care, when I first read about it, I thought, well, sure, that's what health departments do, and didn't pay much more attention to it. And when Dr. Shea first introduced the concept or this topic for today's session, I thought, I better review again what was this concept of the triple aim and what about the integrator role. So in thinking about the integrator role and what local health departments do, I like to ground myself going back to the Institute of Medicine's definition or mission of what public health is to see, well, what's being discussed, does that really fit in the mission of public health? And that's the fulfilling of society's interests in assuring conditions in which people can be healthy. So yes, I can check that box. Yes, it fits with the mission. So then the next is looking at NACCHO, at their operational definition of a functional health department, functional local health department, and I didn't include all of that here on this slide about what that means, but I'd say yes, you know what, that does fit with an operational definition, because it talks a lot about if the services aren't available elsewhere in the public system, in the public health system, then it is an appropriate role for local health departments to be engaged in. And so then that leads me then to my next question always, which is, well, what have my former Hopkins professors taught me, and how does that impact all of this? And since we are here at Johns Hopkins, I feel like it's appropriate for me to bring that up. And what was clear in many of the courses that I took is that the professors would say, really, to be successful in whatever you do, whatever program or policy you implement, you really need to engage the intended beneficiaries from the beginning in all aspects, including the problem identification, but then also the design, the implementation, and the evaluation. So then that's what leads me to the local health improvement process. I suppose I should really go back and share with all of you, it's a confession that I have to make, is that as a local health officer responsible for the health of a population of over 200,000 in a county in Maryland, I was concerned that maybe at the health department we weren't adequately addressing the needs of the community. I know for sure we were addressing needs that we had funding to address. When we would get grants, the grants are for a specific activity and usually for a specific population. And in Maryland, we are fortunate that through the General Assembly and through our counties that they do make funding available to support core public health infrastructure for which there are needs yet not necessarily adequate categorical grants for. So we are fortunate that we do have some ability to address targeted local needs for which there aren't specific grants, but that doesn't quite adequately cover everything. So anyway, I had a concern as a local health officer that maybe there were needs that we weren't adequately addressing, and how do I know from the community whether we really are addressing the needs? And that's really where the local health improvement process comes into play, and I am thankful for the state health improvement process which came out of this, because it really formalized what we were doing at the Frederick County Health Department and set us up, I think, well for the future. So we formally began our local health improvement process. We've done things before with the community, but we started that in October and pulled together 80 stakeholders from the community. We had data presentations, and I'll share some of that with you, as well as Dr. Shea presenting for Frederick County what's some of the baseline data that we have and what are the Healthy People 2010 goals and the Maryland performance in there. And we had small and large group discussions, and then there was voting, because on that day we were identifying what are the top priorities for health improvement in Frederick County. And we ended up coming up with 6 priorities. And what's exciting to me, I'll tell you now. So what was exciting is that I was really only thinking that for the health department, if we're coordinating or probably leading the completion of the strategies or the action plans, I don't know if we could handle more than 4, 5 priorities at the most. But what was exciting is through the process of this day of identifying the priorities is that there was enough community support for the 5th and 6th priority that the folks committed on that day. They said, we commit that we will take responsibility for addressing this priority, identifying the goals, the strategies, and carrying out the actions. I said, well, in that case, then bring it on, put it on the list. And that's what is so exciting about working at the community level, is that we have that ability to be able to work with folks who are knowledgeable and passionate about addressing certain issues. But so just to go back and talk about what was the framework that was presented in identifying what those priorities are, and I thought it was important to start with how many people does it impact, because if it's an issue that impacts just one person, well, that's different from something that affects 50,000 people. And then also, are there disparities? As Dr. Shea had mentioned, that disparities is unfortunately something that we do have in terms of health outcome and access in Maryland, and it's true in Frederick County. And I guess I should boast that in Frederick County, we rank 3rd overall in health in the whole state. And that's according to the national county health rankings that are published now 2 years in a row, and the 3rd year is coming out. So that's great. In Frederick County, we rank 3rd overall in the state. So maybe we don't have any issues to address, but unfortunately that's not the case, is that we have significant disparities in health, and not everybody's able to enjoy the same level of health and well-being. So then the next question that I posed to the group is to consider how significant is the impact. So say it's a situation where it causes you to sneeze once. Well, so even if it affects 50,000 people, but they sneeze once, maybe that's not such a big deal that warrants attention. But if it results in death, so then that is a way to think about that. And then also the disparities. And are there effective strategies to make an impact? There are lots of problems and lots of situations that would benefit from attention, but we might not have effective strategies yet. And I could say to some extent funding, but you'll see on this list, I don't have funding down there. Is there funding for it? The other one is, can the performance be measured so that we can actually tell, are we making an impact? But I don't have funding there. And while, yes, it's definitely critical, and I'd say that with the reduced funding that we've experienced here in the local health departments in Maryland, we are doing less, we're capable of less, we have fewer people to do the work. It still didn't make it to this list. I suggested that people be cognizant of it, but what we came out on the other end with the action plans were all things that could be done without money. It requires people, but not money, not direct money. And so we are in an academic institution right now, so I feel as though I should share that part of the data that we did present to the group is the standard data that is used when you're looking at the health of a population, and that's the leading causes of death. And then also, we did in 2007 perform a community health needs assessment, a formal assessment, including focus groups and a random digit dial of 1,000 households with an oversampling of 200 persons in populated areas where there are many proxies for reduced access to care or poor access to care and poor health outcomes. And that gave us some ideas of what are some areas for opportunity. And so that was taken into consideration. And years of productive lives lost, that's something else from the community that I thought it was important for us to consider is, so it sort of addresses some of the qualitative, I guess not quite qualitative, but when we have these conditions, what does it really mean to our community to have somebody who dies from one of these conditions? And then the health disparities, you'll see there again, we're using death data where there's a whole lot of stuff that goes on between birth and death, including the social determinants that Dr. Shea mentioned. And so, this data still doesn't quite get at it. And so that's where the folks gathered around the table and folks who are part of our larger Frederick County Healthcare Coalition. We've been in existence since about 2006. But what's exciting about that is that with all the data that was presented, with the overwhelming need that existed, there clearly were six priorities for health improvement, which you wouldn't necessarily get from looking at either the state priorities or the birth and death data in Frederick County. You might get at it a little bit if you look at the Behavioral Risk Factors Surveillance Survey. And mental health was the number one priority. Dental access for adults, access to care in general, wellness and prevention, health disparities, and early childhood growth and development. So it's been about 6 months, and thinking about that triple aim, and again, improving the experience of care, sort of the access to care, and also the cost of care. And I see that that's actually the action plans that the coalition developed actually address those, and I didn't even know it. So here, all this time, we were already responding to that vision of the triple aim. The Frederick County Healthcare Coalition is a cooperative effort of, I'd say, the larger community, as well as the hospital and the health department. And when I think about the integrators and that integrator role, in the absence of a specific entity serving as that role, I'd say our coalition is doing that, with the main contributors being the health department and the local hospital. So short of there being an officially designated accountable care organization, it's the health department, the hospital, and our coalition that is working to really meet that ideal of the triple aim and the 5 components of the integrator role. It's been great to look back in 6 months and see that, well, we actually have addressed the experience of healthcare. We've worked on developing some materials for physician practices as well as individuals regarding the ability to have, or the right to have, interpretation available at the time of healthcare services being provided. And supporting local practices, local healthcare providers, and being able to make that a reality and reduce the cost burden that there is with that. We've developed an ACSOurce resource guide. We've already, with the help of using the state's dental health literacy campaign, we've been able to piggyback on that, and we've done a couple local television shows related to that. One of our community partners has received a grant to integrate primary care and mental health care together. We've had a fundraiser, media coverage for some other things, a community transformation grant. We've submitted for one of those grants, and an example of the suicide data. For years, Frederick County's suicide rate has been higher than other jurisdictions in Maryland, and so this is actually what prompted us to take a look at it. And with the awareness of other people at the priority setting meeting, we're able to bring some other folks to the table who are saying, oh, okay, so let's take a look at that and what might be some of the contributing factors to that, as well as what might be some opportunities for us to make a difference in that. And we've made progress also in the pursuing the feasibility of a 24-hour mental health care sort of walk-in type clinic to reduce inappropriate ED use, and that's just what fits on one page. So it is exciting to see that what folks in the community, I mean, you can talk about all this data and the death data, but bringing the community together in the coalition, they know about the experience of healthcare. and they know about the access to health care. So now, as a health officer, I feel much more comfortable and confident that how we're proceeding is doing what we should be doing, which is being responsive to the community's interests and needs. So it provides me much more professional satisfaction to know that, this framework that Dr. Shea identified, the state health improvement process and the local health improvement process, which includes the coalition and the strong partnership with the hospital and the health department, that we can do it, and we already are making a difference. So I'm so excited about that. So for any of you out there, I encourage you to join the coalition. I did recently start Twitter and emailed Dr. Shea yesterday with our Twitter, I don't know what you call it, address. And our Facebook webpage will be going live shortly for the health department. I expect that a lot of the tweets and Facebook updates will be related to our local health improvement process and plan. And I'd like to say thank you. And at this point, I think Molly comes back up and we'll be happy to take any questions.
Okay, great. Thank you. A great big thank you to both Dr. Brookmyer and Dr. Shea. And this is a point in our program where we are open for questions and answers, both from our live audience here as well as those of you watching online. And just a reminder, if you are watching online, you can simply click on the link on your screen to send in a question for either or both of our presenters today. So I do ask, if you have a question here in the audience, if you could use one of these two microphones on either side, just so that the people watching online can also benefit from your question. So do we have any questions for Dr. Brookmyer or Dr. Shea? I think we have one from our online audience, so we're going to start with that. And this is for Dr. Brookmyer. Why did you set your local health priorities by outcomes rather than the behavior that you wanted to change?
I think I went through the presentation perhaps a little too quickly. It actually wasn't, and I realize now if I would have provided the actual goals, besides just the topic heading of mental health and adult dental access, the wellness and prevention, that you'd see that we were actually largely focused on addressing behaviors related and not the outcomes. So that's one of the things that that is challenging. I did ask that when the priorities were being set, that people think about whether there is measurable, whether it's possible to measure what it is that you're looking to change. But in reality, that didn't affect what people developed, what the work groups that have met and continuing to meet have identified for their action strategies. A lot of it is about behavior, because we realize that behavior has everything to do with, I'm sure it's more than just a lot, I think it maybe has everything to do with what people do. So we all know we should eat better, exercise more, and do lots of other things, but we're not doing it, and it's that behavior that has a lot to do with, in addition to social determinants of health, which also impacts behavior. So I'd be happy to provide a much longer presentation going into the details of our local health improvement plan.
Okay. And then here's a question for Dr. Shea. How much could you improve the desired health outcomes by improving SES, and what could you do?
We know SES has a lot to do with health outcomes. Education, that's why one of our 39 measures is high school graduation. And we also, Frederick County prioritized kindergarten readiness as we know a huge determinant of later health outcomes. So I didn't mention, but the SHIP was not just about providing data, it was also about providing tools for action. We have very rich evidence-based tools by objective, in Spanish, overarching tools, connecting the coalitions to resources of all kinds at individual level or for planners, for clinicians. So there are things we can do. to raise SES. There are evidence-based practices, and a lot of it has to do with education and supports for a good start. We collaborate with the Governor's Office of Children. Many of their results that they care about have to do with these SES factors, and we have measures related to that and tools. So.
Okay. And I have gotten a note that our link for our questions online is not working for everyone. So if you want to just email us a question, you can email it to our email address at MAPHTC, that's for Mid-Atlantic Public Health Training Center, MAPHTC at jhsph.edu. So do we have any questions from our live audience? Okay. I'm going to give people just a minute to email in some more questions, since it does seem to be a little bit of a technical difficulty. And we do have another question here. And this is again for Dr. Shea. How do you measure experience of care, and does that correlate with the health outcomes in Maryland?
I would leave that for a dissertation. That's really a huge question. However, some of the coalitions have looked at this. So one coalition in Western Maryland looked at a model out of AHRQ, Agency for Health Research and Quality, and the IOM are promoting the experience of care, this two-way communication, being a very, very important strategy to increase or improve the experience of care. So that's one way. And what we do with SHIP, we're a connector. We're a framework. So when we have questions like this, if a coalition asks that, we would be all about figuring out exactly how do you measure that and how do we improve it. So where we have seen is a method that's being used and diffused right now is this two-way communication, not thinking that because I spoke the almighty clinician or whatever, that that was understood. So that would be one approach. I don't know, maybe you have thoughts too.
Yes, I do, and this is also a plea for anybody out there who is interested in helping us. So the coalition and part of the local health improvement process, folks who are passionate about issues, committed to, implementing action steps to address those. And in our local health improvement plan, there is so much more that we could do to improve our community's experience, the access to care, the cost of care. But what's in the plan is limited to what we knew that there was a commitment from the community to address. And I think that's so important. We could look at what the state has for the 39 priorities, or however that's termed. And yeah, they're relevant, but there's no point in putting it in our plan if we don't have folks who are committed to saying, yes, this is an issue, and let's work on that. Because I think if you look at the behavioral change model, that first you have to get folks who are committed to the topic. And one of the things that I would like to do that I think we can do a better job in that I think there's a Surgeon General's report out from several years ago, is the experience of care for persons with disabilities, that they are less likely to receive the preventive care, all kinds of things. And I think when we talk about the experience of healthcare, I am looking for someone out there, especially someone in Frederick County, but somebody out there who wants to help us to start to make a difference in addressing the experience of care for persons with disabilities in our local community. So that's my answer is, the experience of care, if we have folks out there who are interested in that, I can bring lots of resources and networking to the table and ideas, but I just don't have a person to do it. I don't have the time myself, and I don't have spare people who are waiting for projects. They're all fully committed, fully occupied. So whether that's an intern from McDaniel College or somewhere, but that's part of how we will go about in the future local health departments and state health departments and being able to effectively address public health problems is through the partnerships with the community and the reliance on the community taking this on and saying, yes, this is an issue, let's work together in addressing it.
Yeah, there's a question here. If you wouldn't mind walking to the mic, that way people online could hear you. Or otherwise, if we could just repeat the question.
I have a kind of generic question that raises very sensitive issues. I'm cared for at the Baltimore VA hospital. And when you come in for an appointment, particularly for your general physician, you are screened when you check in by either a nurse practitioner or physician's assistant. They want to know how you're feeling, they take your weight and your blood pressure. And for the last 2 years, when they found out that I was in and out of healthcare since 1943, starting with the Army and working at the University Medical Center in Ann Arbor and at Hopkins, they sometimes unload on me. And one of the complaints that I'm getting consistently is that they are very disturbed with the incoming generation of young physicians who are being house staff and working at the VA or being candidates for joining their staff. And the complaint is that they are becoming increasingly dependent upon laboratories and imaging, and they really are not skilled or motivated anymore to do a really complete, comprehensive health care history or a physical exam. They in fact said some of the young physicians do not know how to do a physical exam anymore. And it seems to me when we talk about both the experience of healthcare and the outcome, if our young physicians do not have the training and the motivation to do this, we're going to have a serious problem down the road. And I'm not sure how your local coalitions can deal with this. I'm sure that maybe you have physicians on your coalitions, and I don't know how you can politely and strategically deal with this issue as these people are seeing it emerge.
I could say a little bit on the state level and then see what Dr. Brookmyer would like to say. With the attention to quality and cost, care that's not effective is going to be more brought to light. So, for example, hospital readmissions, there's really strict attention to that now and consequences for where ineffective care leads to more readmissions. And then in terms of primary care, where people are ending up in emergency departments for things that should have been picked up and managed in primary care. So the system's moving that way, and I can't speak at all to the VA system, but I'm imagining it would follow the same principles. So in the whole health system, there is attention on that based on, because what you're speaking of would drive up costs and drive up costs of care. So I don't know what your thoughts are on this.
Well, it is challenging. So the question of, for those who are on the viewing audience who may not have heard the situation, and the question is, the newer physicians and newer physicians, maybe not all healthcare providers, but the newer physicians appear to increasingly be relying on labs and imaging rather than a good history and physical exam. And what role might local coalitions or really the payers of healthcare be able to do about that? So I think the local coalitions, when I just mentioned the part about looking for someone locally or some group of folks locally to identify what can we do to improve the experience and the access to healthcare for persons with disabilities, what I'm envisioning is first there would be one, an identification of, so what is the status? But number two is identify what might be some strategies that community healthcare providers could put into place, perhaps on a range of costs, but increase their awareness of, did you know that if you don't have an exam table that can go down to a lower level, that is more likely to result in certain persons not coming in for their annual gynecologic exam, for example. So there are so first it might be awareness that, did you know that if X or Y, then that is presenting a significant barrier to persons with a particular type of disability. And so I would say for practicing physicians, if we look at practicing physicians right now, one of the approaches that we have and can take is the awareness of a particular barrier that's being presented. Then what Dr. Shea mentioned is on the payment end that there are incentives being built into at the federal level as well as the state level to try to encourage approaches that would reduce the readmissions and reduce certain conditions. And maybe the way to do that is to sit down and listen a little bit more. The old professors of medicine would probably say, really from standing in the doorway and observing the patient and then also doing a good history plus a physical exam, but you can get a lot from the history. The individual, your patient, might actually answer the question if you listen and you ask the right questions. At the local level, we're in Frederick County and really elsewhere, I'd say, throughout the country, is we don't have as much control over the health professions training, and that's where we need to look at our academic institutions. At the federal government side, there are grants for primary care medicine that include as an objective to improve the quality of healthcare and to provide education related to the importance of a good history and physical exam and how to do that. But I think that's where it would be good to turn the attention and the interest to the academic training institutions, because what someone is likely to do after they've practiced has a lot to do with what they learn. So during their formative period, that is a time that for many practice patterns later on, that's the formative period and where you're most likely to get the greatest bang for your buck.
We know that the postdoctoral experience is critical, and we know that a lot of physicians, at least in the old days, used to choose where they wanted to practice based on their house staff experience.
Right, the greatest determinant of where, it had been that the greatest determinant of where a physician will practice once they're done with their training is where they completed their residency training.
Okay.
You're welcome, and good luck with that. But I'd say also, if you don't get paid for an hour exam, then, and that's one of the challenges with primary care practices versus a procedure that a physician might perform, is that you don't get adequately compensated for that intellectual time and the time.
Okay. Anne, did you like to
go? So I'm Ann Langley. I work for the Johns Hopkins Health System. Dr. Shea and I know each other. We have 4 hospitals, 4 Maryland hospitals in 3 jurisdictions. So we have experience with a few different types of coalitions. I'll take a second with the last question. I thought I really appreciate your answers. What you're identifying is a huge problem. I think that healthcare reform, the triple aim, and the efforts at the state and local level are all, we're positioned to really make a change in this area because the incentives are changing. And when you're only paid for lab tests and images, that's what you do. And we really see, in our program at the Access Partnership, see a huge potential here to re-educate ourselves about the importance of good primary care, because you can't improve quality, you can't lower costs, and you can't improve the patient experience without good primary care. At least that's our view. So we see great opportunities for improving this in the next 3 or 4 years. My questions for you all is, and I guess, Maddie and I have talked about this. I feel most challenged with our city hospitals. So I'd like to hear about your experience in Frederick County to guide us somewhat. In the city we have, so we're trying to, use the state health improvement process to guide our efforts to be more collaborative, more focused, to try to be able to make a greater difference with the resources that we have. It's like drinking from a fire hose. There's no shortage of health indicators that need to be improved upon. And there's no shortage of activities of all the hospitals and lots of other people. I'm most familiar with what the hospitals do, but there's lots of other activity. It's how do you choose, and what's the best way for the local health department to share expertise? I mean, that's really what I'm looking for is, okay, we've got 10 hospitals with 10 different cardiovascular programs. How do we move these towards a couple of programs that are going to actually make a difference? And how do you do that as a local health officer?
Are you sure you mean to direct that one to me? No. I'm fortunate that in Frederick County we have one hospital, and that hospital is a not-for-profit hospital and has a long history in the community of being interested in addressing the community's concerns and needs. Part of it involves patients. So you mentioned it's like drinking from a fire hose. When our community health needs assessment in 2007 was completed, sure, there was that list of areas of opportunity, but a lot has to do with timing, and there was interest from the community, including the funding community, the charitable givers, to address prenatal care. We had a significant issue in Frederick County back in 2007 and 2006 that at any given time there were 100 women who were pregnant living in the county, and our county population was just above 200,000. We had at any given time 100 women who were pregnant and had no prenatal care. So the hospital, after the assessment came out, we had a coalition meeting to identify what are the biggest needs and interests. They were able to rally their board as well as the funders around addressing that one issue. There were still lots of other ones. And then stroke. We have a relatively higher rate of stroke and I think also mortality from that. And that again, so there was the data, but it was coupled with interest in the community from persons, from the providers, from the funders, plus other factors that contribute to it being a good business decision to put in an interventional cardiology program, and a stroke prevention program. So our experience in Frederick County is having one hospital. It makes it a lot easier to be collaborative. And for the local health department to share the expertise, the way we've been doing that, approaching that is when it comes down to the action plans, or so say if you look at a root cause for any particular condition and what are the various contributing factors to that, maybe all the time, we would come out to something that does, that there could be a public health intervention that might affect that. And so that's where it's pretty much sitting down around the table saying, okay, so what are all the factors contributing to this? And looking at those factors, do we in the health department, are we aware of anyone else who is either addressing that or that we've addressed that in other ways, or that we know of resources that and evidence-based practices that could be brought to bear here? And so frequently what my job is, Dr. Shea mentioned that she's the connector, is I find that frequently my role, maybe half my role during the day, is to connect people to other people and to other resources that will help them to be more effective in what they're doing.
So can I ask a quick follow-up? So was there this is another issue that we have. There are a lot of programs in the city and a lot of really effective ones and some that are less effective. Did you ever sit around a table or see a community come to a decision to say, you know what Dr. Brookmyer just said, this program over here doesn't meet any of those criteria. We need to stop doing this and put those resources over here.
I think we'll be getting to that point as resources, both from governmental programs, resources from corporations, from hospitals, and from the charitable donors. Resources are reducing, and there's also greater awareness out there on the streets of evidence-based practices and an empowerment to say we demand that we get the best product for our money. I think as funders begin to demand that, then we will see that communities will be developing asset maps to say, sure, we have all these programs. This is what you're getting for your money in those programs. These are the services. This is how these programs differ from each other in terms of the population served or the type of services provided. So it might appear as though there's some overlap, but there isn't. And it might also include looking at what might be available to assess the quality or at least the return on investment. I expect that we will see more of that in the next couple of years, that funders, the charitable funders, will be asking to demand that, as well as our local governments and our state governments will be asking to see that return on investment.
Thank you.
We have a few more questions from our online audience, and this is for either of you, if you know of any systems in place now or have ideas for what could be in place for how we could share best practices information between coalitions from different states and other jurisdictions. And this is a question from New York.
That's a big component of the SHIP. So through our social media, our newsletter, our website, we are promoting best practices, sharing those, and as now that we're clear on where the coalition's priorities are, those will become more and more focused on where we know the needs are. So, and then the other website in terms of clinical innovations on the state health department's webpage is another place where you can see that. But that's a lot of what we're about, promoting sharing. And we'll probably look at more face-to-face type engagement among coalition leaders around specific topics in this coming year and 2 years.
And I guess I'd say it's probably up to me to make sure I'm not the weakest link in the chain, is to make sure that Dr. Shea has the information that she needs to put up there. But we already have, for those who are in local health departments, the National Association of City County Health Officials. They have several publications that when they show up, because we still receive some print publications, as well as email ones that highlight interventions that are taking place in other health departments to address issues, and it is one of the publications that I do look forward to reading because frequently I will find that they are addressing something that is of interest to us and that we get ideas from that. But I guess I must make a commitment to you, Dr. Shea, that I will send you our information and make it so that people are aware of what we've produced, because I expect several of the things that we're producing to increase awareness and education and outreach will be applicable no matter where in the United States people might want to apply them.
It's really great how some of this happens just through partnerships. So again, going to the Mid-Shore, they didn't have experience around population health planning and partnerships around that. But one of their partners was their local management boards who address social services and foster care needs. And they had a lot of experience with planning. And so they brought the tools for results-based accountability to the table. The hospital, everyone was charged up about this. They have the most amazing plan. So best practices can even come through the people at the table. Like we're all about helping it, but it's amazing how much of that's embodied in really when you have a happening coalition.
Okay, great. I think we have time for one more question, and we have one from our online audience. And I guess this is for Dr. Shea. You mentioned the paradigm pyramid shift from a focus on individual and programs/services to a population-based approach centered on implementing policy systems and environmental change strategies. How has this change impacted your workforce and your thoughts about public health workforce development?
We have work to do on the infrastructure side here because it definitely affects the skills that we need to apply in our jobs in public health. So assessment, partnering, how to partner, how to build coalitions, how to assess what's going on. These are, so people with public health degrees will have those skills, but we have all kinds of people working in public health that may or may not. So if their focus had been clinical, on delivering a particular service, they might have natural aptitudes, but not have the packaging for it, and to do some of these new functions, these essential public health functions. So we do need to, and will be looking at, in terms of public health infrastructure in Maryland, how we can support all of the public health workforce to make this change, this shift.
Okay. I think that wraps it up for today. Again, I want to really give a big thanks to Dr. Brookmyer and Dr. Shea.